Thank you all for joining. We are Hip Hope Network webinar, recruiting for clinical trials with Dr. Dan Perry. And I will turn it over to Dr. Shaker for a brief introduction.
Great. Thank you so much, Tamara, and thank you so much, Dr. Perry, for joining us. So it is an absolute pleasure for us to have the opportunity to learn from Dr. Dan Perry's extensive expertise this morning, or this afternoon, this evening, wherever you might be joining us from. So just by way of brief introduction, Dr. Dan Perry is an NIHR research professor with the UK National Institute of Health Research and a consultant children's orthopedic surgeon at Children's Hospital, where his clinical focus is on pediatric hip diseases and trauma. And he is also the BOA specialty lead for pediatric orthopedic clinical trials. So Dr. Perry trained in Liverpool and Warwick before completing a fellowship at Sick Kids Hospital in Toronto, Canada. And he is the first orthopedic surgeon to have been awarded a prestigious NIHR research professorship with a focus on developing a nationwide platform trial to optimize the detection and treatment of developmental dysplasia of the hip in infants. Dr. Perry leads an extensive amount of research in children's trauma, orthopedics, and emergencies, a portfolio of international clinical trials totaling more than 30 million pounds or 40 million US dollars in grant funding, including orthopedic studies such as FORCE, SCIENCE, CRAFT, BOSS, PICBONE, OddSOX, OP Nonstop, BASIS, and a trial in pediatrics about UTIs called CURLY. He has a prolific publication record totaling over 150 papers, including in The Lancet, JAMA, and BMJ. And his academic love is to make clinical research accessible for children, parents, and clinicians. He integrates cartoons, animations, videos, and uses text messages to make trials easy for everyone. So he works with a thriving group of children and families who contribute to his research by advising on the design and conduct of the studies, and together they have developed the way that research materials are delivered to families. And the success of the enrollment in his clinical trials is a true testament to the effectiveness of his inclusive and creative approach. So Dr. Perry is also a member of the NIHR HTA General Board, is the orthopedic trials lead for the Royal College of Surgeons, and an editor of the Bone and Joint Journal, and is the clinical lead for hip screening within Public Health England. So we are truly grateful to get to learn from him today. Thank you and welcome, Dr. Perry, and please take it away.
Cool. Well, thank you for having me. So let me firstly share my screen, which is always the most difficult part of every meeting, to make sure we've got sound. Okay. So I think you can see my desktop. So I know that you guys are kind of at the beginning of your trials journey, in terms of doing clinical trials across the world, with Kishore very much focusing on a big worldwide approach to doing trials. And in the UK, we've been fortunate over the last sort of 6 years or so, we've been building a big trials portfolio. And whenever we start doing randomized controlled trials, they're actually really hard, and they're a lot harder to do, and a lot harder to get patients on board than we actually think they're going to be. And so my team, my research team has actually grown now to, as well as including surgeons and statisticians and health economists, my research team's also got a qualitative researcher, which is an expert in patient experience, and a psychologist. And the psychologist is very much, as well as figuring out how to get the families on board, it's also about how to get the surgeons on board and how to teach the surgeons and the nurses and everyone else involved in the recruitment of patients, how to get them on board. So this talk is going to be a bit different compared to a normal surgical talk. We're going to talk about a bit of psychology and a bit about how we're going to sell studies that the families are going to want to be on board with. So we've mentioned a little bit what we built in the UK. In 2015, we had no research. Now we've got this fancy research guide with a load of different studies. We've got a fancy website, which is called totsresearch.org. And these are some of our study logos, which is kind of cool. So we've got some experience in delivering it. And our first study was published in the Lancet, and we've got a few more coming in the next year, which is really cool and really exciting. So the big thing I want to talk about is equipoise. And equipoise is that state of uncertainty where where we're not sure of what the best approach is when we're doing a randomized controlled trial. So we're not sure whether we should be doing treatment A or treatment B. And that state of equipoise is what we've got as clinicians. So we have community equipoise. And so one of the things we did in the UK is we looked at distal radius fractures. And we wanted to know what the state of equipoise was around distal radius fractures in terms of displaced distal radius fractures. And so we know there was community equipoise, and we needed to learn how to convey our equipoise, how to convey our uncertainty to families in a way that we could get them on board. And it's very much about picking up the patient's brains and learning what words to say and what words not to say in order to get families on board with clinical trials, because it's really, really, really difficult. And it's not easy. And you all imagine when you start a clinical trial, you're going to think, I'm going to be the best person at recruiting, but it's really, really difficult, but it is worth it. And so just at the outset, I'm going to tell you some things that are gonna make you sink or potentially swim in terms of trigger words that families are going to dislike when we're doing clinical trials. Firstly, the word trial. Families hate the word trial. Trial is what happens to guinea pigs. Trial is what happens to guinea pigs in a lab. They get trialed upon. And no family wants their kid in a trial. So the first thing I teach all of the surgeons and all of the guys that work with us is it's not a trial, it's a study. So whenever we're going to do this, we're always going to do studies. And we're going to randomize. And so we have to think about how we're going to talk about randomization. And what we're not going to talk about is rolling a dice or tossing a coin. We know that this is what you kind of, these are the obvious ways we explain it to families, but families perceive this as trivializing randomization. Equally, they don't like the computers deciding their treatment. What they do like is fairness. So they like the idea of fairly choosing between two interventions, using a process called randomization. You can make it scientific, but you're not going to say computer. You're not going to trivialize it with roller coaster, toss a coin. And this isn't just me that's kind of saying this. This is there's lots of psychological research that comes out of recruitment with clinicians about what families like and what families don't like. And then if you've got two treatments, so you've got a new treatment and an old treatment, well, guess what families are going to want? They're going to want the new treatment. No family wants the old treatment. And also the word natural is amazing. You can lead families into whatever situation you want if you use the word natural, because everyone wants natural treatment. And so one of the studies that we did, we threw in the word. It wasn't recruiting very well because we were comparing surgery and no surgery, and families all wanted no surgery until we chucked in the word natural, and we said that surgery is going to put the bone back in the right position to allow it to heal naturally. And just by changing a wee tiny thing, we actually swung the whole conversation round, because families have got a real passion and a real desire to have natural treatment, even if it's surgical treatment, which is encouraging natural healing. It's really bizarre, but the little things that you say are so important when we're doing clinical trials. So look, this is me with one of my coordinators, and I'm pretending to be the doctor, and she's been the patient. And this is about a situation about distal radius fractures. So off-ended distal radius fractures. We all know this is a controversial area, and I was trying to explain it kind of badly about how we were going to do this study of off-ended distal radius fractures. And I want you to think as you go, think about the good things that I'm doing and the bad things that I'm doing. Hi, I'm Dan. I'm one of the surgeons. So your child has come in today because they've got a broken arm, and they've got a broken arm and the bones have moved out of place. In the UK, we treat these fractures. So traditionally, we treat these fractures in different ways. The gold standard treatment is to take them to theatre to put the bones quickly back in the right position and make them nice and straight. The alternative, which is what we used to do, but before we started doing surgery, was to leave the bones overlapping so they're out of place, allow them to heal, and then over the course of a few months, see if the bones straighten on their own, which is often the case because kids are magical. So we've got a randomized controlled trial whereby we do the gold standard treatment versus the older kind of more old-fashioned treatment, but the one we think works probably just as well. I wondered if we can encourage your child to participate.
So
we'll stop it there. So I kind of said all the right things. So I kind of had a conversation which was reasonable, and it wasn't the worst conversation that I could have had. But I said a lot of words that didn't fill the person with confidence. So we talked about old-fashioned treatment versus new treatment. We talked about what else did we talk about? Talked about so we kind of see if it's straight in. So I wasn't convinced in my own way. We talked about the word trial. There was just lots of stuff that just wasn't right. That wasn't going to convince the patient. And so I encourage you when you start randomizing, and I know it's the most stupid, unnatural thing in the world, and it's like being back at med school, and you all think you're really, really good at randomizing, but I promise you that you're not, in the nicest possible way. And so I encourage you all to do silly role plays, and ask each other what it feels like. So in the UK last year, we had 100 people in a room. Jim Wright was there from Sick Kids. And we made everyone do role plays, and it makes people feel really, really uncomfortable, but it's so valuable because we're not as good at this as we think. So this is one where I think I did it a little bit better. So if we're going to do supportive words about this, we want to talk about both treatments being good treatments. We want to reassure families that whatever happens, we'll look after you. And we want to sell the whole idea of fairness. So we're not going to, so it's not new treatment versus no treatment. The two treatments are equally as good. And the whole thing about fairness in terms of that's what randomization is there for. So randomization is to make this whole process fair. And that's how you explain randomization. So here. Hello, I'm Mr. Perry, one of the surgeons. So today, your child has got a broken wrist, and so the wrist bones have moved slightly out of place. Around the world, doctors treat this in different ways. Traditionally, in the UK, we've been fairly interventional, so we've tended to take children like your child to theatre to put the bones back in the right position. But oddly, around the world, particularly North America, they've not done it the same way. They've tended to put the child in a nice plaster, allow it to heal, and kids are cool. So as the bone heals, it actually grows itself in a nice straight position. But there's lots of uncertainty about which is best, which of the two approaches best, whether to do surgery straight away, or whether to treat it in a plaster and allow the bone to heal naturally. So we doctors recognise the situation is crazy. In the UK, we've all got together and said, look, we need to decide which of these two treatments is best. So we've started doing a big national study whereby children are allocated fairly between one of the two groups. And so today we'd like to invite your child to be part of that. So that was much more fair, much more balanced, and we had a whole approach of fairness. And it was much more difficult to choose between the two interventions, which is exactly what we want the family to be. We want the family to be sitting on the fence, because once they're sitting on the fence, you can then push them. You can push them in order to take part. So what if a family says, well, I've listened to what you're saying and I don't want to take part in the study?
Okay. And if I don't take part in the trial, what would be the option today? Would it be surgery?
Yeah, so prior to the study, as I say, we did surgery. So my recommendation would be for you to be part of the study. Children inside studies generally have better outcomes than outside studies, and that's called the trial effect. If you weren't in it, we'd have to make a decision about which is best for your child, or which we perceive is best, but I'm genuinely uncertain. I don't know which is the right way. And on that basis, I prefer your child to be in the study.
Okay.
So if they don't want to take part, firstly, I think it's really important to say it's okay to challenge that. So it's okay to say, look, why don't you want to be part of the study? Because we've got the trial effect, and the trial effect demonstrates that children in science studies, irrespective of it, have better outcomes. So the trial effect is a good thing. And so then what if a family says, what if they say, no, we don't want to be part of the study, we want intervention A or intervention B? Is it okay to challenge that?
If there doesn't need to be a big operation and there's a kind of a quicker, more straightforward option, keyhole, that would be my preferred choice, I think.
Okay, so I understand that. So obviously keyhole, keyhole is a smaller operation, but it doesn't change the fact that the hip bone in the long term, it isn't going to be normal. So in short, it's okay to challenge it. It's okay to say, look, if you don't want to be part of the study, why don't you want to be part of the study? What's going on? Because this is common misconception that if a family says, okay, I don't want to be part of the study, there's a common misconception that it's unethical to challenge that, but it's not unethical. It's perfectly legitimate to go back and say, look, why have you made that decision? What's causing you to say no to being part of the study? Because we know that once it's a family said no, if we talk to them and try and understand what's influenced that decision, we can win more than 50% of those families back and pull them back into the study. And so it's okay to challenge it if a family says no. And then the other big thing that I always talk to my people, my groups in the UK, is about if they change treatment. So if a family gets randomized to treatment, in your case to brace treatment, and they suddenly change their mind and don't want brace treatment, want the alternative, do you then withdraw them from the study? And the simple answer is no, don't withdraw them from the study. Once they're randomized into the study, they're in the study forever, unless they specifically say, I don't want to be part of the study, I don't want my data in the study. And only then do you withdraw them, because if you want to keep them in at all costs, because then we'll deal with them as an intention to treat participants. So once they're randomized, they're in the study forever, unless in the really unlikely exception that they say they don't want their data in. But even if they change treatment or whatever happens to them, they're in the study because they're really, really important to the randomization and really, really important to the statisticians. So I'm not going to talk for long and we can have a conversation, but every word that you say to families is important. I'd encourage you to do loads of role play. Think about the trigger words that you're going to say in randomization. So a computer will decide, throwing a dice, rolling a coin, new treatments, old treatments, traditional treatments, and the word trial. Like all of these have got lots of negative connotations, and you need to really, really think about what you're going to do. And we need to think about balance. So balance between the two interventions, and how we're going to lay out the balance. And it's okay to challenge decisions. If a family says, I really, really want treatment A, it's okay to say, oh, okay, but let's just explore why you want that. Because it may be that their next door neighbor had that, and it may be, something completely irrelevant to the decision we're having then. So it's okay to challenge decisions. It's okay to challenge if a patient says no. It's all legitimate. It's all part of normal trial practice. And once they're randomized, they're in it forever. You keep that patient in there forever unless they specifically say, no, I don't want my data in this study. So in your study, you're looking at bracing versus no bracing, or bracing versus nothing. And so I think you as a group need to think, and you may have already done this, but how are you going to frame that? How are you going to frame bracing versus nothing? Because you've got something versus nothing, and you can possibly predict which way families are going to decide. Families generally have got their poor child in front of them, and they want there to do something, and therefore you can argue that they may well want bracing, want intervention versus nothing. So one of the studies we've done recently is a study about Perthes disease, where we're comparing surgery versus physiotherapy. So many patients regard that as not a big intervention, as nothing, if you like. So in order to do that, we've really dressed up this physiotherapy intervention to have it a really cool intervention that families really, really want to buy into. So we've got surgery versus a really cool active containment intervention is what we've called it. So we've changed the word nothing to active containment. So we've got surgical containment versus active containment. So it's much more balanced. And I think when you're presenting this to patients, you need to think about the balance to make sure that families are going to be equally as perplexed as you are about what the right intervention is. The way that we do it is at the beginning of the study, we'll write out what I think is probably a perfect pitch for each of the studies. We'll discuss it now with psychologists to make sure the psychologist equally thinks it's the perfect pitch. And we'll show it to some families who are on our patient groups to ask them, are you on the fence? And once a family's on the fence and the family's sitting there in front of you and saying, "Oh my gosh, I don't know what to do. I don't know, which way to turn." That's the perfect place to say to them, "Look, you don't know which way to turn. I don't know which way to turn. Let's just randomize you. Let's get the result of what we're going to treat you in the study, and at that point we can make a decision, and we can decide if that's the legitimate way forward for you." So that was my whistle-stop tour about sort of the psychology of clinical trials. And I know it was quick, but I know it's early for you guys. And I hope it's helpful, and I'm more than happy to answer any questions. But I think that's the biggest challenge that we have in clinical trials. It's all about the psychology with the patients. And if you can get that right, then you're beating us.
Thank you very much, Dr. Perry. That was great. Definitely learned a lot in that bit as well. We just had one question from Bhushan in the chat, who put in at some point on one of your slides asking what's the trial effect that you were referring to.
Okay, so the trial effect or the study effect is the very nature of being in a study. Your outcomes are generally better than not being in the study, particularly if it's 2 routine interventions. So if you've got 2 routine interventions, patients inside the study will have better outcomes than people outside the study. And that's probably because you get better monitoring, you get closer, you get watched a bit more closely, and you feel a bit more loved. So there's a bit more placebo going on. So generally you can encourage families to be in a study because of the trial effect.
Great, thank you. And please feel free, anybody else, to either unmute and ask any questions or put questions in the chat. But while we wait for, Jason, yes, go ahead.
Hi, Dan. Thanks very much for doing this. We had a granted study recently, where people had to do a little bit extra to be involved with it. Some of our patients had to drive significant distances because it was an MRI-based study, so they needed to do it at our center. And we had tremendous problems with recruitment because of that in position. And one of our young research coordinators said, you could sweeten the pot and offer them a gift. And we ended up offering them some of our budget for a gift card or something. I can't remember. But it was something not $25. It needed something like $100 to get people really interested to come. And I just want and we got the recruitment then, in a few months. And we were running out of time, so it was important that we got that recruitment. I kind of thought it was a little bit, I wasn't super comfortable with it. What are your thoughts about using gifts and sort of incentives for patients, particularly when they're being put out to be part of the study?
Yeah. So I guess ethically that is always, there's always challenges around it. So we routinely offer all of our patients a gift card. We justify it on the basis that they have to reply by text message to all of our things. And so we justify it in the basis that we're kind of recompensing them for any of their costs. And it's always small, it's like $20 or something. So I don't think a family should ever be out of pocket for being in a study. Because I think that would be wrong. So I think giving them sufficient monetary incentive that they're not going to be out of pocket is completely legitimate. I think giving them more than that, people can start to debate a little bit, because then it becomes part of the intervention. It becomes part of the placebo. They're getting paid to be part of the study, and that's not necessarily then real practice.
No, exactly. There's definitely a balance there. So thanks for your comments.
Cool.
Great. Thanks, Dr. Hart. And we have a great question from Dr. Carrie Calais in the chat. So, hi, Dan, great talk. What kind of feedback have you had after the fact from families about the recruitment experience they had? For carers that initially decline, I'm mindful that there might be cultural differences in how carers perceive being challenged. Any insights on this?
Yeah, okay. So we actually do quite a lot of research, which is all published, which is called qualitative research, where after the studies, kind of during the recruitment stage of the studies, we have our qualitative researchers who are like expert interviewer psychology people, and they'll go and speak to the families and ask about the recruitment experience, and the families, even the families that didn't recruit to the study, they'll ask about their recruitment experience. And that way we can try and influence what we're saying and guide the clinicians about what we're saying to see whether we can change our processes. And so generally recruitment experiences are good, and I think they've got better as we've got better as a group of clinicians. There's always some families that feel a bit pressured to be part of the study, and they're often unhappy, if I'm honest. They're often unhappy about kind of the pressure they felt. And a lot of our studies are emergency medicine studies, so they're often in the ED, and they're kind of, you're either going to get a reduction or you're not going to get a reduction, and we need to decide now. And I don't necessarily, well, that's often how it's put to them. And I don't think you guys are necessarily going to be in that place, but certainly families like time to decide things, and they like kind of making decisions at their own pace. So I think if you can give them information about the study beforehand in a way that's balanced and kind of goes through the nuances, then I think that'd be helpful. One of the big things that puts people off as well is, for us, if a patient goes to the ED with a whatever fracture, and the ED doctor or the medical student that knows nothing about that injury, if they look at the X-ray and say, "Oh my gosh, this is the worst fracture I've ever seen," then there's no way in the world that patient is going to be treated non-operatively, irrespective of how useless that medical student was. And so it's really, really helpful to look at your referral networks, and your referral networks that are coming into you, because if you're being referred by someone and they say, "We always treat this in this way," then, or we always know that whichever hospital treats it in this way, then there's no chance you're gonna be able to convince that patient to randomize, or very little chance. So you need to think about your referral networks, where the patient's coming from, and make sure those patients are influenced as well. Which is why all of my trauma studies all run with both ED and orthopedics combined, because then we can control the whole pathway. Yeah, but there are always cultural differences in different patients, and you have to be mindful of that, and try and approach that appropriately. Yeah.
Great, thank you. And we also have a question from Dr. Rajuta Mehta in the chat. So how do we handle potential trouble, as in if for some reason the patient is dissatisfied and feels their child got the wrong treatment halfway down the RCT?
So we do have a little bit of that. I think so especially in the sort of studies that we're doing, we're generally comparing two different routine treatments, and I guess the biggest, bravest one I've done is about offended distal radius fractures in kids, where we treated 350 of them without surgery. And there were a few families dissatisfied at 3 months or 4 months because their child had got a bendy wrist or a bendy arm. And I think those families, you just need to spend time listening to them like you would any other family, and you need to just reassure them and just keep them. I think one of your missions is to try your hardest to win back your patient relationship, but also to keep them in the study and keep them going with it. We all know that we all have patients that for whatever reason kind of don't like us, fall out with us, don't like the treatment we've got, and sometimes those families can actually be your happiest families at the end of it all, because you have this breakdown in a relationship, you build it back up, and sometimes it can be really positive. So I think some of that's inevitable, but you've all got super great clinical skills that you can win that round. And I think just remember, these are routine treatments, but patients are going to get one or the other.
Great, thank you. And so do you have, I guess, in your setup, a lot of it you're comparing, in comparison to ours, where we're comparing like bracing versus observation, yours are seemingly a lot is like comparing two different interventions. Do your clinic, or is it a mix of them?
It's a bit of a mix. It all depends how you I think it all depends how you sell this observation thing.
Yeah.
Because we've got a lot of studies which are surgery versus no surgery. So doing something in a patient's mind, doing something versus not doing something. And I think one of the risks you've got is this observation is potentially a problem. And I don't know, because families, you can spin it that you're not being treated and therefore that's a good thing. But I do, these families are going to be quite worried about their baby. I guess one of my concerns is that they're going to go home, sit there worrying that they're not treating their child, and they could be doing something relatively simple. And so why would they wait? Let's just put on a brace. And I think we need to think about how you might counter that and how you might use different words.
Yeah.
And so there was so all of this psychology in trials actually came out of a prostate cancer trial. So there was a prostate cancer trial in the UK, which was comparing surgery versus watchful wait for prostate cancer. And patients perceived that it was surgery versus watch me die, was the way that patients perceived it. And so a psychologist came in and talked to some patients doing these qualitative interviews and changed the watchful waiting to active monitoring. So instead of kind of simple observation, it was active monitoring. And by doing that, they completely changed the whole recruitment process. And they were then able to recruit, and they successfully recruited to this big prostate cancer trial. And this is where the whole psychology in clinical trials and surgical trials was born, from this group in Bristol in the UK called Jenny Donovan. So I think that's your challenge, and I think you need to perhaps think about how you might influence your conversation around this observation.
Yeah, no, that's great points. And I think we do refer to it as active monitoring in our protocol, but I don't know if we refer to it as active monitoring in our, in our script, so-called. So, but we have had, I think, and Elisa, our nurse practitioner who's on the call, can correct me if I'm wrong. I think we have had families that have been hesitant or wanting both sides of this coin, where they preferred to do observation or they preferred to do bracing. So we do have definitely sort of like hesitance or a desire to do one side or the other on both sides of the coin with our trials that we've encountered so far.
Yeah, and I think that's really common, and I think it's really important to collect that preference. And so you might then change your trial material to try and, if it's very unbalanced, change your trial material to swing it back into the preference. But also when the clinicians are talking to the families, if they say, no, I prefer, I don't want to be part of the study because I prefer whichever intervention, then you can just kind of pull back and say, well, actually, have you thought that this brace is going to be really difficult? It might interfere with family life. Perhaps we do need to go back and think about randomizing or think about being part of the study, because that's the only way we're going to fairly decide this. And it's okay to challenge them. It's okay to be a bit argumentative and a bit playful, because that's legit. That's part of normal life.
Yeah, exactly. Okay, we have a couple more questions that came through in the chat. One from Dr. Giovanni Santillan. Inside this time-directed biascientism, how do we guarantee to reels on diverse forms of possible beneficial treatments in the diversity of global medicine? Are the bias in sort of paper published paradoxical barriers for research? Parents are inside the internet, the global internet, before going to the hospital.
That's a tough question. I'm not sure I can answer that. Yeah, so patients are certainly well informed before they come and see us. I think it's our job to kind of pull them on side to explain the uncertainty and get them part of us.
Definitely a tough question, I agree. And we also have one from Yasmin Haler. So thank you for this great talk. Patients often want to be part of a study, but it's sometimes challenging to get your colleagues to participate in multi-center studies. Some more of a comment. We've certainly seen in our study various clinicians being either hesitant one side or the other, and both sides. I'm not sure what your thoughts are on that. And
Yeah, so again, this was something we had. Something we still have to a certain extent, but it was much bigger problem early on, and then you start to get people on board, and as you get more and more people on board, there's that kind of tipping point where people actually are knocking on your door to come on board. I think it's difficult. I think it's winning hearts and minds. I think it's getting people on board. They start to see the research process. I think research has got lots of benefits beyond the actual study, which I think clinicians start to see. So as an example, we've got a study called BASIS about scoliosis, and my spine surgeons initially didn't want to do it because our spine department, the orthotists kind of were a bit dysfunctional and it wasn't working. And I encouraged them to get on board, and we had lots of talk about how to randomize. And one of them came up to me a couple of weeks ago and said, actually getting on board with this study was the best thing we ever did, because now we've completely changed our relationship with our orthotics department. It's completely revolutionized our service. And I think that's the big thing about research. So research, it is important for the patient, but we also know that it really, really improves clinical services. And so I think that's a really good carrot to offer your colleagues to say, look, you know, we know that the best led hospitals, the best led units are very active in clinical research. And so, you know, I think that's a good carrot, but it is about winning hearts and minds, and it's a slow going process at first.
I agree. Yeah, we seem to be picking up momentum on that side too on our end. So it's come. And so do you have largely your clinicians that do, the surgeons and clinicians that do the recruitment and the sort of discussing with the parents and families, or do you also have your research coordinators that do that?
So we've got a mix. So we have research nurses in all of our hospitals. But if we're very honest, the clinician has to be the one. Well, I believe that the clinician has to be the one that kind of introduces the study and says, we've got this perfect study. I want you to be part of it. And that's the clinician's role. And then if we're also honest, then surgeons are generally less good at having the balanced, equipoised conversation. Because the coordinators are often better at that because they've got more time to do it, and also because they've kind of watched the videos and thought and done the practice and thought about what they might say. So we have a mix. The other people that we have that are very involved with our stuff is the surgical trainees. We have what's called an associate PI system. So in each hospital there's a group of surgical trainees that basically want to recruit to studies because we'll give them certificates and we'll give them kind of points for their CV and stuff for being part of the study. So we do have we've built a really great network amongst our surgeons, our trainee surgeons, and our kind of wider research staff.
Great, fantastic. I haven't seen any more questions come in through the chat. If there's any last questions coming through, please do speak up or put them in the chat now. Right. Shall we wrap it tomorrow then with no questions coming up, or what are your thoughts?
Yeah.
Yeah, I suppose. Any closing thoughts, Dr. Perry, that have come up?
No, I mean, I think taking on trials is really difficult. Yeah, I think it's really cool to share experiences between different trial groups around the world. I'm always more than happy to talk to you guys about any aspect of our trials. And what we talked about today was a bit niche, a bit kind of like, you know, psychology of recruitment, kind of a bit weird, and people don't think they need to think about that. But I think it's one of the biggest things that we have to learn about in trials. And it's the thing that we won't learn at med school, and it's the thing that we won't learn anywhere else. So we need to kind of go back and, you know, understand it.
No, absolutely.
I have a quick question before we wrap. How did you develop your relationship with the psychologists in your hospital or your clinical network?
So initially, so there's a group called Quintet in Bristol, which I mentioned, who did the prostate cancer trial. And so they now do courses for surgeons to encourage surgeons to recruit to clinical trials. And they run a bunch of different courses. So I asked them to speak to our trials group in the UK. And that's where I learned all about the words that we shouldn't say, like rolling a dice and tossing a coin and all of this. And then consequently, they come and spoke to us a few times. And then they were speaking so much that I figured it was probably worth, as a group, employing a psychologist. And that's why we now have a psychologist and qualitative researchers and kind of a much bigger team, in addition to the traditional trials team members.
Fabulous. So thank you so much, Dr. Perry, for joining us and for giving such an informative and valuable webinar on recruitment for RCTs. Just a quick plug, we will be having another similar lecture series on the draft method with a few lecturers in January of next year, led by Dr. Ogmuller. So we are going to be sending out some save the dates about that very shortly. I hope that you can all join. And thank you again, Dr. Perry, so much for giving me your time for this. And thank you everyone for joining. So great to have all your questions and your participation.
Yes, thank you so much for a great talk today.
Cool. Cheers, guys. Nice to speak to you.
Thanks.